Okay. Hello, good morning to everyone. It's our great pleasure to be here and to have you numerous here. Thank you, the EURETINA, for organizing this session. So the MicroPulse and PASCAL in the world of retinal treatments. I think this is an important topic in the era of intravitreal injection. So we still need to know where is the place of the laser and what is its role in the management of retinal diseases. So we will have 4 presentations. The first one will be given by Dr. Boris Stanzel from Germany. It will be on MicroPulse photostimulation as a supplement or substitute to anti-VEGF therapy in retinal vein occlusion. After his presentation, we will do the discussion of this presentation, and thereafter we will have 3 other presentations with the final discussion. So Boris, please, the podium is yours. So I just want to say this is an interactive session, so please ask the questions and we will be very happy to address them.
Okay, good morning. So if you think of this presentation as a rock concert, so I'm just a pre-band, the rock stars are still coming. But one thing I want you to take home is that basically you know, MicroPulse laser offers you the opportunity to retreat, and that perhaps may be relevant for vein occlusion. So let me take you through that, why I think that is the case. So these are my disclosures. This is really the core of this presentation. This is Dr. Van der Broek. She's a very talented resident in our clinic. She collated a lot of the information in this talk. So I want to start off with a case of a 47-year-old male who basically presented to us about 2.5 years ago. And he had his past medical history is significant for non-Hodgkin lymphoma. He had a decreased visual acuity in his right eye, and turns out that he had macular edema and flame-shaped hemorrhages at the upper vascular arch. And the diagnosis of a branch vein occlusion with cystoid macular edema was made. This is what it looked like when we first saw him, and you can clearly see that there's basically a significant swelling of the retina at the upper arcades. And this is what it looked like. There was already some degree of retinal reorganization here, and then we started a upload of anti-VEGF, and obviously you know that in the first year of treating vein occlusions, there's a relatively high VEGF demand, and this was the case with this patient as well, and so he still kept having fluid, so we switched him from bevacizumab to ranibizumab with the idea of having greater drying strength intraretinally. And at some point, we reached, let me go back, we reached the point that we felt, well, he's getting a lot of injections, and the patient started asking me, okay, is there anything else? And so I said, well, yes, I saw some presentation at a conference, and we can try that. And so this patient really turned out to be a very interesting case because he converted my thinking. And so what we did is that first, we wanted to make sure that he has a response to anti-VEGF, and this is the patient 2 weeks after VEGF, and you can see that his retina is nice and dry, but he does have, if you compare the nasal and the temporal part of the retina, already some ischemic changes. We know retinal ischemia is a driver for macular edema, right? And anyway, and so then we did the MicroPulse laser. There's also one thing to note about this patient. He has a tremendous fear from injections. So every time he had an injection, he required general anesthesia. So perfect case there to try something new in that sense. And so this is the patient 2 weeks after MicroPulse laser. Notice that there's a recurrence of the edema. We're like, okay, his visual acuity is still 1.0, 20/20, so we said, okay, we'll just observe. Okay. He came back a month later, and then basically his visual acuity dropped, obviously macular edema there, so we're like, okay, well, we need to do another VEGF injection, and that's worked as well, but we also said, okay, we need to do a repeat MicroPulse laser. You know, think of Anti-VEGF, you do a 3 times upload of injections, and we think that may be the same here. And so we then did a MicroPulse laser, and then basically he remained dry thereafter, and had perhaps a small cyst. Okay, we injected again, and long story short, to just in the interest of time as well, that patient then has, after the 3rd MicroPulse laser, every time 2 months apart, remained dry over a year time and maintained his visual acuity of 0.8, 1.0. You know, keep in mind that he had retinal ischemia already. Okay, here, 12 months after the 3rd MicroPulse. You see that the macular configuration is near normal if you forego the drill changes in the inner retina. So this is a summary of the case. You can basically see that basically after MicroPulse laser, his need for anti-VEGF treatment decreased dramatically, but I stress this was achieved in combination with anti-VEGF. And always anti-VEGF, 2 weeks later, MicroPulse, and we did the retreatment basically with about 2 to 3 months intervals at the time. And we think that this cumulative effect really plays a role. So not just one time, oh, it doesn't work, okay, forget it. Just keep going with the injections. Okay, so we've done more of this based on this patient experience, and I would like to present you some 11 patients with branched retinal vein occlusion. These are fairly balanced with, in terms of males and females. The age was 65 years plus minus, and we used all kinds of anti-VEGFs, not just bevacizumab, but all the 3 available treatments, and there was not just, sometimes there was 1 treatment. On average, we had about 2 MicroPulse treatments. And you can see basically that there is a clear pro in terms of visual acuity here with this chart. That the post-MicroPulse patients clearly seem to be there seem to be more patients benefiting with a higher visual acuity thereafter. Also, the central foveal thickness progression seemed to be always, or in most cases, stabilized after after the MicroPulse treatment, except for this one patient, but he then responded extremely favorable. And here is basically, and this is the most important chart, the decrease in need for anti-VEGF therapy after MicroPulse, and you can clearly see that a lot of patients actually, we tend to say about 2/3 now, had a drop in the amount of anti-VEGF injections thereafter. And keep in mind that the follow-up time here was over a year in the mean follow-up time. Okay, so one thing to say though, that the limitation here is this is a retrospective series, and then the other thing is that these results are not statistically significant simply because this is a too small sample group and it's a very diverse baseline and treatment passes. Essentially, you know, the term there is real life. Okay, so now just in the interest of time, just to quickly take you forward. So there's a number of, not so many studies on branched retinal vein occlusion, but I strongly would like to point you to this paper by Ted Lang from Stanford, who really summarized quite well the evidence available at the moment, and a paper out of Japan that treated patients who were treatment naive with anti-VEGF alone or with MicroPulse and VEGF, and it turns out that there was a favor of patients who had MicroPulse treatment and anti-VEGF, but these patients only had one treatment with MicroPulse, in my understanding. Okay, now in terms of laser settings, EURETINA provides you with their standard 9 grids. We are doing more than that. We are doing 30 grids. And it appears to be that the larger area you recruit for irradiation, the more of an effect you seem to have. At least we've seen that with particularly the vein occlusion patients. And this is the pattern. So we also go beyond the arcade in terms of achieving that. And we do titrate. I must stress this. So this is something that we think is relevant because there's always some media changes, and the larger the spot size, the more there seems to be also possibilities for threshold burns. Okay, so now just in the interest of time also just one thing that I want to present you, because there's no real strong literature about this. This is a patient who has had a central vein occlusion, first presented 4 years ago to us. A 53-year-old male, initial visual acuity was 0.8, but 2 weeks later he came in with a very thick macular edema. You can see 700 microns, and then basically after an upload with anti-VEGF, you can see clearly ischemic changes in the retina. The patient did receive pan-retinal laser coagulation. There's this ghost saying that if you do pan-retinal laser coagulation, you decrease VEGF-D drive. That's not true, and I've cited you some literature here. So in other words, laser coagulation does not seem to really decrease anti-VEGF drive, but we did MicroPulse laser on this guy as well, and it was a lot more sporadic in terms of the repetition than you've seen on the vein occlusion patients. But the message here is as well that basically in combination with anti-VEGF 2 weeks later, MicroPulse laser, you can achieve a dry macula. And there is after the initial MicroPulse laser, you will have some recurrence of the edema. That seems to be perhaps some of the effect how the MicroPulse works, because it does induce remodeling, perhaps some slight inflammation. But don't fear that, and talk to the patient about that. Do anti-VEGF, it responds to that well, and then repetition is key. And that's how you can slow the need for anti-VEGF medications. Thank you.
Thank you, Boris. Any question from the audience? While we are waiting for the questions, just one thing. You brought up several points that I think will be the topic of discussion about, for example, the titration or not titration. And just if you can tell us how do you do the retreatment? So what is the time difference when you retreat the patients with the laser, and what is also the time interval when you compare it with intravitreal injections?
Yeah. Okay.
In your clinical practice.
Yeah. So our rationale for the intervals between lasers is that the MicroPulse treatment induces a heat shock reaction in the retina, and so there's a change in gene expression that lasts about 2 to 3 months, and so we felt okay to err on the safe side. We basically gonna give that effect 2 months, and thereafter we retreat. And so irrespective of macular edema, we will have that 2 months interval. But if there is macular edema in the vein occlusion patients, we do the anti-VEGF as well. And so the rationale for us is to have anti-VEGF prior to MicroPulse to ensure that the retina is dry, so that there is a very uniform laser deposition, so that you are not impeded with macular edema, and thereby the laser gets lessened.
Okay, thank you. Please.
Hi, I'm Ken from Malaysia. Thank you. I enjoyed the talk, and I totally agree about the need for laser. I think I've been doing this for 10 years, so I think a lot of the initial problems with beginner users is titration. So maybe it's good to share how you titrate. You go outside the macula, how do you do it? Do you do it the 5% duty cycle, increase the power, and then reduce by half? I mean, I think those are the points that a lot of users worldwide are confused about. And when they publish results, you're not comparing apples to apples, because you're getting differential results from different settings.
Yeah.
Thank you.
Fully agreed. Yeah. So I follow the IRDEX guidelines of titrating, and so we do our titration spots at the arcades. I usually tend to find like a little branching pattern where I know I can recognize my spot, and I do wait. Okay, so I do my laser burn and make sure I'm well focused. The patient didn't move or something, because once you have a movement artifact, basically the laser energy gets diverted or diluted, if you will. And so I do wait maybe 1 or 2 minutes to see if that outer retinal edema comes up. And that's essentially my threshold. I titrate with a 200 micron spot, and it's a continuous wave. And then basically the continuous wave, say if, just a practical example, if you basically have a 200 millisecond time and the power is 70 milliwatts, then according to EURETINA, you multiply by 4. And so then you would arrive at a 7 times 4 is 28, so 280 milliwatts. So, and then I turn to a 5% duty cycle, and that has worked for us very well. We've done over 1,000 MicroPulse treatments, and that worked very fine with us.
Okay, thank you. Paulo.
Boris, very nice presentation. Very informative. It's very nice to see that you're doing more spots of because what we've seen with PASCAL and endpoint management was that the lower the intensity, the more surface area that we need to treat seems to be about surface area. And you made another comment on VEGF. There's very nice evidence suggesting that it is the area of watershed or hypoxia that drives VEGF and not the ischemic, what's already ischemic. Yeah. So that's why treating the ischemic doesn't really change. You're right. Yeah, and this was actually quite. I felt this case was also that the central vein occlusion case was quite interesting because he was very ischemic, right? And so also in terms of his VEGF need, he was untypical because if you go into real life evidence, that the patients will need some 5 or 6 injections in the first year, and then in the second, third year, that need for anti-VEGF goes down to 2 or 3 at most, right? And so this patient was really untypical because he had a very high VEGF drive, and so, but being able in such an ischemic situation to, when he started out with 0.1 visual acuity with MicroPulse, to get him up to a 0.25 visual acuity and nearly significantly decreased VEGF drive, huge improvement in quality of life of an individual who is still in his working age, mid 50-year-old guy. So yeah.
Okay. Okay. Thank you. We will need to move on. Okay, so my presentation will be on new data on MicroPulse laser treatment in DME. So let's see. It is uploading. No? Okay, these are my financial disclosures. So definitely the MicroPulse laser is a revolution in the retinal treatment of retinal diseases. It has shown to be a safe and effective treatment that does not damage the retina, but it normalizes or restores its function. And it is a very important point, I would say. However, the lack of standardization has limited its use in clinical practice. In fact, if we talk about different, let's say, points in the treatment of retinal treatment, we will find, as we discussed before with our colleagues, a disagreement in how to treat the patients, if to use the titration or not. And with the other colleagues I saw here, Professor Battaglia Parodi and the others, we published this paper recently on some, let's say, standardized parameters that should be used when you treat retinal diseases. So it is definitely a low-intensity treatment. It should be a high-density treatment, so with a lot of spots on the retina, or on the macula, or the posterior pole. You should not titrate, but you should use the fixed parameters, and also how to perform the treatment. You can even retreat the same areas in the same session. So the therapeutic mechanism, what is it? It has been debated quite long, and now there has been a lot of, I would say, different papers recently published, that it acts like, let's say, a reset stimulus that normalizes the RPE function, but also it allows to decrease the production of inflammatory cytokines, VEGF and matrix metalloproteinases, and also it reduces reduces the aqueous humor concentration of some different cytokines that are secreted or released by the glial cells in the retina, so both the microglia and the microglial cells in the retina. In fact, in this clinical study, for example, when we evaluated patients that were treated with a subthreshold MicroPulse laser with 577 nanometers, we found that if you look at the thickness of specific retinal layers, the major decrease is located in the inner nuclear layer, and that is the layer where the nuclei of the microglial cells are located. Also recently, this Japanese experimental work that was done in vitro evaluated the differential gene expression after the application of continuous wavelength laser compared to the subthreshold MicroPulse laser. And they evaluated these human pluripotent stem cells derived from RPE cells. And what they found, this was really interesting, early after the treatment, so 3 and 24 hours after the treatment, that there was a different gene expression after these two types of laser treatment. So continuous wavelength laser upregulated the expression of these differential genes that were involved in the vasculature development related to apoptosis and repair after cell injury, whereas the MicroPulse laser expressed the genes that were involved in the photoreceptor cell maintenance, photoreceptor cell development, and sensory perceptions of light stimuli. So this also may explain, let's say, these different molecular mechanisms of laser-induced thermal effects. So the safety and efficacy of the MicroPulse laser has been reported by different, I would say, authors and in different prospective randomized studies, and it has been clinically evaluated on different imaging modalities. We know color fundus photo, fundus autofluorescence, OCT, and recently also on OCTA. So in these studies, we performed several studies. We found that there were some microvascular changes in the retina after the subthreshold MicroPulse laser treatment, in the sense that with the OCTA, we found the major changes in the deep capillary plexus. So, for example, the decrease in the number of the microaneurysms, even if the microaneurysms are not the direct, let's say, target of our treatment. It's not that we are targeting the microaneurysms directly. And also, there was a decrease of, for example, the cysts, both in the superficial and in the deep capillary plexus, and also the decrease in the drill extension, so disorganization of the inner retinal layers, and the decrease in some inflammatory signs, such as the hyperreflective retinal spots, the signs of the activation of the microglial cells in the retina. So whether the effect of the MicroPulse is just on the RPE or it is also on the RPE that then modulates also the glial cells in the retina, it remains something definitely to be evaluated in order to understand better how this, let's say, inflammatory response in the retina is reduced after this type of treatment. So what are the current indications for the treatment in DME with the subthreshold MicroPulse laser? It is the mild center-involving DME with good visual acuity, or also non-center-involving DME. You can associate it with the intravitreal injection, so in the combined treatment, patients who refuse injections, or for example, patients who cannot undergo the intravitreal injections. And now we have some new data, both on the combined treatment and also an important, I would say, randomized multicenter trial on the use of the MicroPulse laser in mild edema, so in edema with less than 400 microns. So, for example, this was a study that was performed in Germany, a recall study, single phase 4 prospective study, where two groups of patients were compared, the patients with DME that received initial 3 intravitreal injections of ranibizumab, so it was the loading phase, and thereafter they were divided in two groups, one that continued the ranibizumab treatment with the PRN regimen, and the other that had MicroPulse laser, and the patients were followed for 1 year of follow-up. The primary endpoint was the change in best-corrected visual acuity at 12 months. So what the trial showed? The trial showed that the group that had the combined treatment, so the MicroPulse laser and the intravitreal injections, had a lower number of injections after 1 year of treatment, so 7.46 injections when compared to 9.68 injections in the just intravitreal injection group treatment. The visual acuity increased in both treatment arms, and the central macular thickness decreased in both treatment arms. And there was, let's say, this borderline significance, so it was not statistically significant, but a trend toward a greater improvement in the visual acuity in the combined treatment group. Another study, this was the UK study, multicenter study, that was performed in 16 sites across the UK. The Diamond study that has just been published, you see in the August number of the Ophthalmology. It was the pragmatic investigator-led multicenter randomized non-inferiority double mask clinical trial where the subthreshold MicroPulse laser was compared to continuous wavelength laser in patients with DME and with the central retinal thickness less than 400 micron in the fovea. The primary outcome was the mean change in visual acuity, best-corrected visual acuity, from baseline to month 24, so 2-year study. And you can see here all the secondary outcomes of the treatment. So you can see that the patients involved in the study had quite high visual acuity, so 80 letters of the ETDRS, so it is 20/25 Snellen equivalent, so they were starting for high visual acuity, and the mean central retinal thickness you see was 329 micron. So the significant difference in the change in visual acuity was considered 5 letters of the ETDRS. So when the two treatment arms, so continuous wavelength and the MicroPulse laser, were compared, there was you can see this change on the, let's say, a decrease of 2.43 letters of the ETDRS in the MicroPulse laser and 0.45, so a change of less than 2 letters that was not considered clinically relevant. So it reached this, let's say, significance, but not clinically relevant. In both treatment, let's say, statistical analysis, so as per protocol or the ITT statistical analysis. What about the secondary outcomes? There was no significant difference between the two treatment arms. The only difference was in the number of laser treatment. So you can see that in the 2-year follow-up, it was a little bit higher for the MicroPulse laser group, so 2.4 laser treatments, whereas in the standard laser, it was 1.9 laser treatments. The majority of the patients, you see more than 95% of participants, fulfilled the driving standards at month 24. So no statistically significant difference in the secondary outcomes. And so the conclusion of the study was that the MicroPulse laser was equivalent to the standard laser in patients with central involving diabetic macular edema and central retinal thickness less than 400 micron. So as it is the cheap treatment option and effective treatment option, it should be offered to people with DME and this retinal thickness of less than 400 microns. And with this, I have finished. Thank you. We will move now to the next presentation. It is Professor Midena, and then we will have the discussion at the end. Thank you.
Good morning, everybody. Thank you, Stella. Thank you to EURETIX. My presentation will be a little bit erratic. I'm using the subthreshold micropulse for 20 years. And I think that some points need to be fixed, because we continue with the evolution technologically, we continue with the evolution of indications, but we don't necessarily have to repeat many, many times the same concepts. One point, we are not speaking about just micropulse. We are speaking about subthreshold micropulse, meaning a laser treatment approach according to a modern technology which spares the retina. Nothing happens morphologically, functionally at the retinal level, and particularly the external part of the retina, where there is the problem with the traditional laser. This is one of the reasons why after 20 years we have no more to compare this kind of technology with the old one. It's similar to the cataract surgeon who is using the technique of 20 years ago. The second point is that I think that when we have consolidated data, already performed randomized trials, even with not an enormous number of people because there are not so many financing behind laser versus drugs, but it's okay, it's established, as in any part of medicine. And also the parameters for the treatment. This is a point that Stella underlined. I personally think we should avoid to consider, this is a personal opinion, but repeating in the literature, and I learned this one around 20 years ago, that the concept of titration is, from my point of view, has no sense at all, considering that science has shown us that it is useless. I'll discuss a little bit about the research, the basic research behind the scenes, and what we know at the moment. It's correct. When I report data on MicroPulse laser subthreshold at medical meetings where the prevalence is the intravitreal injection, I seem a dinosaur, because the standard treatment seems to be the comparative. But we don't want to burn the external retina. We don't want to destroy any retinal cells. Very simple. I abolished the use of standard laser in my department around 20 years ago. On the other side, you have to remember that particularly in diabetes, 50% of eyes are unresponsive to VEGF. So there is something intriguing behind this. And I think that this is correctly the best model to understand the real use of this kind of laser approach. Because on the same time, the same study, the protocol T, demonstrated that in 50% of eyes not responding to anti-VEGF, the rescue was laser treatment. Unfortunately, was the traditional laser treatment, inducing microscotoma, as we have shown with microperimetry. So fixed parameters, I think they are mandatory. It's very simple. If you use titration, you'll never use subthreshold micropulse. Never. Because I don't know which is the thickness of the retina exactly where I'm performing the titration. I don't know so many things as the question before, that when I can say Jeff Lutrul 20 years ago developed the idea of fixed parameters, and I follow him, it was absolutely correct. Why? Because as I show you and demonstrate you, this is not a problem of energy at the pigment epithelium level, where titration may be an idea, not necessarily correct, but an idea. So we are using fixed parameter. We were using this one with diode, infrared. We are now using different parameters with a yellow one. We may provide you. We don't need any visible subthreshold change and no side effects on the functional point of view. Very simple. We tested many times, we published a lot with any kind of technique, recently with adaptive optics too. So when I was preparing this presentation, I realized that our study, Stella, dates back to 11 years ago. We made a randomized trial. I think this is just repeated by the diamond one. It was a randomized traditional laser treatment DMAD versus subthreshold micropulse. So we don't need, it's a very nice study, diamond, but it is an old concept, already demonstrated. Why demonstrate continuously? This is not a problem of different drugs or approaches. And we recently reviewed our experience of hundreds of cases. We have treated thousands of cases at that moment. The concept is that with subthreshold micropulse laser, at least theoretically, but practically, it's useless if you treat a patient with thickness in the fovea, central fovea area more than 400 microns. It depends on the specific way of acting of this laser. You may honestly reduce the thickness of the retina if it is higher, with the intravitreal injection, for example, any drug you like, and then in a couple of weeks, when the retina flattens, you use subthreshold micropulse to have the maintenance of this effect, or you treat the patient with less than 400 directly with micropulse. I wrote about it in an interval of 3 months. This is not a fast technique. It's a fast technique, but not a fast result. By biologic definition, you cannot have an effect, I show you why, of this kind of laser treatment in 15 days or 1 month. You may have some subtle changes, but not the effect of the laser. You need to wait at least 3 months and then repeat the treatment with the same parameter over the same area. In this study, we have seen that we need at least 3 treatments to have a persistent of effects on mild diabetic macular edema. And this is our procedure. We planned 3 treatments in 1 year. Very simple. The patient has his list of appointments, and then we will judge the final results. The concept of the use of subthreshold micropulse rests on a basic concept, that in these years, the pathophysiology of macular edema is radically changed. The key actors are no more circulation, are the glial and the inflammatory cells in the retina. They are the key actor of the story. And we need to work at this level, not at the level of microaneurysms as it was 40 or 50 years ago in the initial studies made on both sides of the Atlantic Ocean. Something has changed. One point, why we are not rusting more in animal models? Very simply, because the anatomy is not the same. This is not mine, the text of this slide. It's from a very important paper analyzing the new concept in macular edema. The experimental part, if you have human models, is absolutely crazy most of the time. This is the reason why more than 10 years ago, I introduced the concept, which is well known in medicine, which is the concept of liquid biopsy in the eye. And we are sampling to prove what we are saying scientifically with the analysis of fluids in the eye in patients treated with subthreshold micropulse. What really happens in the human eye in this specific macular edema condition? And we have found that it depends on the microglial cells. It's the Muller cells the driver of water inside the retina. There is no vessels competing with the Muller cells. The Muller cells, you have to remember that physiologically is the first producer of VEGF, even when there is no ischemia at all, because it's a normal reaction of this cell. And so the liquid biopsy approach allowed us to demonstrate in humans. These are the results of the study we made analyzing in 1 year the biochemical parameters inside the eye of patient treated every 3 months with MicroPulse. And you see that when we have one in 1 year, and you see that some effects is becoming present at 9 months. So 1 month is nothing. 3 months, just the beginning. That these are inflammatory biomarkers, because macular edema is driven by inflammation if it doesn't appear. But I can tell you that we have OCT biomarkers showing you that this is the real story. But this is another topic. VEGF decreases. VEGF decreased in these eyes just with MicroPulse. They were never treated with any anti-VEGF. This is the reason why with my subthreshold MicroPulse, I'm not treating the vessels. I'm treating something else. But what I am really treating? I am treating something related to the key actor of this phenomenon, meaning the Müller cells, because there is a restoration of the activity of these cells inside the eye after subthreshold MicroPulse. And this is the story that I can show you with a fixed treatment, with fixed parameters, in a fixed way, DME in this case. So he recently published something summarizing this idea from the clinical side, and thousands of cases, from the science side, from the application of standard parameters, up when we will understand the applicating fixed parameters is the solution to open the door to this kind of modern laser treatment, as a friend of mine is defining this technology, we will rest in a small, limited group of people thinking that this is another idea. One point is that, and it is stressed many times, and according to me, is unproven, that the effect of subthreshold MicroPulse is again at the level of the pigment epithelium. Wrong, absolutely wrong, because in the same eyes, we sampled and calculated the amount of the parameters of the metabolic activity of pigment epithelium. Nothing happens, nothing, no increase, neither decrease. And why you are asking to me why? Because the effect is not at the level of the pigment epithelium. And this is the right reason why it's absolutely safe. The external part of the retina is never modified by this kind of approach. I conclude, I'm not to use clinical cases, but I conclude with something about this, to show you. All the cases I'm showing you are not diabetic macular edema or retinal vascular occlusion, are the other applications of this laser. Because this laser currently may be commonly applied to most of the cases, if not all, to most of the cases of macular edema induced by different pathogenetic mechanism, from the secondary effect of most biologic drugs used by the oncologists at the moment, the MEK inhibitors, just to mention, or the reaction in this case to ocular irradiation due to the treatment of this eye, for example, for an extrafoveal malignant melanoma. We are concluding a more than a 2-year study on this particular complication. This is the fact of the treatment, no other therapy. Or if you like, to move to the serious detachment over a dome-shaped, for example, or when you have a chronic central seizure cardiac retinopathy, over-treated before, photodynamic, low fluence, eplerenone, everything. We are collecting dozens of cases where patients are arriving because somebody heard about this spatial treatment we are using as first line. because it is not aggressive at all. Every 3 months, please remember, with fixed parameter. You see, this is the proof. I have a lot of cases of macular edema, but I don't want to be tedious with you. I just want to show you what happens. And this is an approach which is continuously growing. So I've been erratic. I agree. But I think to have transferred to you not only my very long-term experience, what is the reality of making a sub-threshold, meaning safe, modern laser treatment. Thank you.
Okay. Thank you. The next presentation will be given by Professor Paulo-Eduardo Stanga from London, UK. So it will be on the current clinical indications and advantages of the PASCAL laser system.
Thank you very much to Franz Weingartner, the EURETIX team, for inviting me. Thank you, Stella, for chairing. These are my commercial associations. If you are here and only use MicroPulse, I'm here to shock you. Let me share with you how I use the PASCAL on a daily basis. So it's important to remember that we have more than the slit lamp as a way to deliver laser into the eye, onto the retina. We have the slit lamp, we have the indirect ophthalmoscope, and of course we have endolaser when we do vitrectomy surgery. So there are different laser technologies, there are different strategies. There isn't one laser, one strategy that suits all patients and all users. And it is essential to remember that. We need to reduce ocular side effects. We need to reduce tissue carbonization, cell loss, laser spot expansion, and functional loss, both in the central area as well as in the periphery. So this is my office, this is my setup. You know, I don't need to remind you what the main indications for laser are. Diabetic retinopathy, macular edema secondary to vein occlusion, and of course, peripheral retinal lesions. I do a lot of treatment of peripheral lesions. So PASCAL, as you know, was developed back in 2005. It was the first pattern scan laser. I've been involved in the clinical development of PASCAL since the very beginning. I had a commercial interest in it. It's a frequency doubled neodymium YAG laser, 532 nanometer wavelength, semi-automated, of course, controlled by the physician with various spot patterns. On the left, you can see that was the very first patient I treated. You can see the pattern there. That was the very first one going straight into the eye with PASCAL. That was the first PASCAL, commercially available PASCAL. We did a lot of work on the clinical side, trying to look at different strategies, different settings. I'm not going to go into that. That's all in the press. So how do I treat myself with PASCAL? Well, I do a lot of targeted photocoagulation and as well as panretinal photocoagulation. And as we'll see later, sometimes you cannot differentiate TRP from PRP. It may be the same. I'm trying to present my data in a very pragmatic way, not just giving you case, talking a lot about the settings, the settings that we use in real life. I do a lot of retinopexy, and I use either the Mainster 165 lens or Folk 2.2 with indirect ophthalmoscopy delivered laser and scleral indentation. I think it's the only way to reach the periphery. The aura, up to the aura, is to do indirect ophthalmoscopy. There's no lens, no contact lens that allows you to reach the aura. We do macular laser as well, of course. So how do we expect, or how do we need laser to be in 2022? Effective, of course, ideally single session. That's not always possible, of course, but for years, we've no longer been doing staged panretinal photocoagulation, as I'll show you later. It's got to be painless. It's got to be easy to map. We need to know where we've been. It's no good if you cannot see where you've been, because otherwise it's not easy to retreat. We need to reduce side effects, and of course, it's got to be safe. So we did a lot of work. We described the use of autofluorescence to map laser lesions several years ago, and we looked with both autofluorescence and OCT at the healing response in the burns. And we showed that with a short or intermediate pulse duration, you could get a reduction in the laser spot rather than expansion, which is what we were used to. So this is a patient that was, as you can see, partially treated. That was partially treated elsewhere, proliferative disease, retrohyaloidal hemorrhage. You are familiar with these findings. I don't need to explain. And this is a single session panretinal photocoagulation. That's the endpoint that I go for. And as you can see, 3,819 laser spots in a single session. 20 millisecond duration, laser power that ranged in this patient between 200 and 500 milliwatts, because the laser power, you have to remember, will depend on, that we need will vary according to the pigmentation, midi-opacity, and even how you tilt the contact lens. And I treat in a patient with severe ischemia from the arcades up to as far into the periphery as possible. And the 4 quadrants. I always start with the inferior one, so if for whatever reason I cannot complete the treatment and there's a vitreous hemorrhage, the vitreous hemorrhage will usually, of course, decant, and at least that area is treated. And you can see the result there at 2 months. You can see the resolution of the proliferative disease without significant carbonization. We no longer go for that extreme carbonization where we are used to. There's no need for that. Of course, in some patients you have to add and repeat the sessions, and then you end up with that end result, but you certainly don't want to have that result after the first treatment. You certainly do not want this. This is a patient treated elsewhere. This is old technique. And here I've added, this is a cardiologist, a patient that happens to be a cardiologist with very poorly controlled diabetes. And I've added a PASCAL laser within the circle, and this is the autofluorescence at a couple of weeks. And as you can see here, you can see the reduction in the neovascularization, the regression in the neovascularization 2 to 3 weeks later. So it is essential to map the areas that you need to treat. I always do in this kind of patients ultra-wide field fundus fluorescein angiography to assess clearly the area that I need to treat. And here you can see, and you've got the dates there. On the left, August the 15th, and here, August the 22nd, you can see the reduction in the fibrosis already in the neovascularization. You can see that the fronts feeding these new vessels have significantly regressed. This is another patient. This is a patient that has only one eye. The other eye underwent vitrectomy elsewhere, and the eye was lost. So he came to see me with his left eye for a second opinion. He had been treated in the past only with anti-VEGF. And then when COVID came, he couldn't undergo any injections, and this is what happened. He had not had any laser. The disease was, they tried to control the proliferative disease just with anti-VEGF, which perhaps works well, but you have to keep on doing the injections. And that's the result. Initially, when I saw him, I said to him, well, I think you're going to need a vitrectomy surgery, but we ended up doing staged panretinal photocoagulation as the hemorrhage was resolving, and you can see how the vitreous cleared. You can see, again, the arcade, you can see the macula again. There's no cystoid macular edema as per OCT scans, and that is only with laser treatment in a staged fashion. This is a patient with a branch retinal vein occlusion that I treated with an Ozurdex initially, and then with ongoing anti-VEGF injections, you can see significant macular edema, not only intraretinal, but also subretinal fluid, thickness of over 600 microns. You can see there the anastomotic and changes, the collaterals, and here are the settings that I used, and it's subthreshold, as we tend to call this. I call this barely visible or invisible laser, because subthreshold is a very loose term. It just literally means below a threshold, but nobody knows what that threshold is. So I call this a subvisible laser. You cannot see it clinically, but you can certainly see it with autofluorescence. And here you can see straight after the laser, the area that I've treated, and you can see, you have the dates there. So January, the first, beginning, then February, and this is March. And you can see the progression, the healing response in the laser spots. And this is part of the work that we've done. So what is the biggest risk of invisible burns? The biggest risk is the lack of therapeutic effect, so you don't miss much. Now, let's move to retinopexy, which is, in my practice, something very important. So this is the husband of one of the members of my staff, a large area of lattice, and as you can see with navigated peripheral OCT scans, you can see that there is an area of subclinical detachment and a very large round hole. So how did so this is what the area looked like, and this is straight after treatment, and here you can see after an indirect ophthalmoscopy with scleral indentation, 444 spots, 200 millisecond durations. You really want to induce scarring there. You want to secure the tissue here. You do need visible lesions. Here there's no room for invisible treatment, and that's the power that I've used. There's another patient, this is a Russian model that was hesitant to have a laser initially. You can see the progression of subretinal fluid, again with peripheral navigated OCT. It was thanks to OCT that I could convince her to really undergo the treatment. So she could see that the retina was elevated, that the vitreous was attached, and you can see there the settings. And again, indirect ophthalmoscopy, I can easily treat up to the aura. It is very common that we get patients that were treated elsewhere, and it is just the posterior edge of a horseshoe tear that gets treated, and that is insufficient. You really need to treat all around. It is the anterior edge of the horseshoe tear where the flap is that is the most important to treat. As a retinal surgeon, we see patients that come with a detachment after laser, and that's because the laser was not carried out 360 degrees around the tear. This is another patient, and here again, do we really need to do PRP 4 quadrants in all patients? Do we really need to ablate functional tissue? And the answer is no. We've published the only 2 so far randomized clinical trials on targeted retinal photocoagulation. That's the setting in my clinic, the ultra-widefield fundus fluorescent angiography. I think it's essential, and this is what has allowed us to do targeted retinal photocoagulation, because we can easily map the areas to treat. And targeted photocoagulation, there is a bit of misunderstanding here. It is not just doing a ring of photocoagulation in the periphery. It's targeting to the area of non-perfusion and the transition zone, because it seems to be the transition zone that stimulates the formation of VEGF. Once the retina is ischemic, dead, it does not seem to stimulate a VEGF formation. So it is important to treat the area of non-perfusion and the transition zone. So what I do is in this case, I would finish the photo. This would be almost like a panretinal photocoagulation because there is a lot of ischemia in this patient. But let me show you other cases. So this is a patient with peripheral ischemia only. You can see the telangiectatic and micro changes, the microaneurysms. You can see the settings there that I've used 20 millisecond duration here. I don't need PEXI. And you can see how I've targeted that area. And every patient that I've treated immediately after, we obtained a record. And this is a month later. You can see very little carbonization of the retina. Another patient with telangiectatic angiomatous changes in the periphery and an area of ischemia. And of course, you need to cover all the area of ischemia, and that's the result a couple of months later. You can see the red-free straight after the laser. So, targeted retinal photocoagulation seems to be as effective as pan-retinal photocoagulation based on the study we've done. However, only if you treat the areas that you need to treat. That is not going to work if you only treat the peripheral retina. Let me share with you other examples of retinopexy. It is very common to see these round holes, and the problem that we face is that we don't really know which lesions we need to treat, which ones we do not need to treat in the periphery. Horseshoe retinal tears, there's no doubt. We always need to treat. Lattice without tears, we do not need to treat, so far as from what we know. The American Academy recommends follow-up monitoring of round holes, but the difficulty is how often do you monitor these patients? What we are seeing now with navigated peripheral OCT is that it's easier to document or diagnose the presence of subretinal fluid. As you can see there, the elevated edge of the hole, and as you can see there also the presence of a vitreoretinal attachment. These lesions I treat, because I think the risk of treatment is very low, especially if the patient does not yet have a PVD, a posterior vitreous detachment, because the question is what will happen with this hole once the patient develops a vitreous detachment. And that's, again, peripheral OCT. This is another example. This is the area of subretinal fluid, the hole, and I surround completely the area of subretinal fluid. That's the type of scarring pigmentation that you want. You really want pigmentation all around any tear or holes when you treat. And I'm reaching the end. This is a patient with an area of peripheral schisis. The fundus fluorescein angiogram, you can see some telangiectatic changes which are not uncommon in the periphery of patients with retinoschisis, but interestingly, inferiorly, it is now covered by the upper eyelid. In this patient, you can see the navigated peripheral OCT here. There was an area of retinal detachment under the area of retinoschisis. And here, this is the peripheral OCT. You can see the defect in the junction between schisis and detachment. And here, you can see clearly the area of retinoschisis, and here the small section of retinal detachment that extended underneath the area of schisis. And this detachment you want to treat before it expands, because these are complex vitrectomy surgeries. So this is the treatment. This is, as you can see from the dates, a month later from when I initially saw the patient. The patient was reluctant to have treatment initially, then came a month later, I treated, and this is another month later. By that time, the laser was pigmented. So the laser goes, as you can see, underneath the area of retinoschisis. So laser versus drugs. As you may remember, before COVID, there was still the question, is there room for laser? Do we need to keep buying laser? Is there a point of lasers being developed and manufactured? And as you can see, it may no longer be a relevant question. There's obviously a role for laser. We cannot treat everybody with injections. It's not feasible. And we have to remember that these are complex diseases. There isn't a recipe for everyone. There isn't a laser for everyone that suits everyone. There isn't a technique that suits everyone. I am a big believer in combination therapy, in the use of either anti-VEGF or steroid, and followed by light laser in the case of macular edema. And we have to remember, again, I'd like to repeat it to finalize, that not all strategies suit all patients. That's the setting in my office, so I can do the laser on the spot, and thank you very much.
Thank you, Paolo. Any questions from the audience? Yes, please.
Peripheral OCT at the Aura, which machine?
Thank you very much for the question. I use two systems. I use either the Canon Cefilio S1 or the Opto Silverstone.
Okay. So the second question is about the laser for areas with traction. There is no break. Don't you think that the laser can cause some vitreous traction and induce the break?
No. No, there's no evidence for that. No, I've never seen it. I don't do laser if there is just traction.
Oh,
only
so you wait when it is, there is a break? Okay.
Only if there is a hole, if the hole has elevated edges and there is traction. If I see a hole, it's a very good question. If I see a round hole without fluid, even if there is traction but without fluid, I'm not going to treat.
Okay, thank you.
Okay. There are several questions online on what are the fixed parameters we use for the subthreshold MicroPulse laser in the treatment of, for example, DME. And I can reply. I know we use the same parameters as Professor Midena. So with the Iridex 577 nanometers laser, we use the 5% duty cycle, 100 microns the diameter, and 250 milliwatt of the power. So with these settings, so without titration, always the standard parameters, if you have also the foveal evolving of edema, so the foveal thickening, you can safely treat also over the fovea. There are several questions also for Professor Midena. If you can treat with these parameters also the edema, macular edema after the vitrectomy, or also the macular edema after phacosurgery. So
I think that there is no limitations about this. The treatment is the same for any case, independent of the situation of post-surgery vitrectomy or something else. The topic, or better, the point of action is inside the retina, not outside the retina.
Okay, so there are also several questions asking in a combination treatment, can you combine the subthreshold MicroPulse laser with the Ozurdex, not just the anti-VEGF? Yes, of course, it is not, let's say, any limitation for the MicroPulse laser. Then there are some questions for you, Paolo. For the patient, for example, if there are new vessels on the optic disc in PDR, but no new vessels on retina, where would you target the PRP laser? How close to the disc would you laser?
That's a very good question. You only treat the area of ischemia, the area, even if there's neovascularization at the disc only. For there to be neovascularization at the disc, you need to have some ischemia. So I do ultra-wide-field fundus fluorescent angiography, and that's what guides the treatment. But you have to remember that to have NVE alone, you must have a lot of ischemia. So most likely that TRP is going to be like a PRP, full PRP. So I'm not suggesting that everybody can have just peripheral laser or targeted. You have to use your common sense, and it varies according to the patient.
Okay. And also the question, what are your parameters for providing subthreshold treatment with PASCAL?
PASCAL has a function called endpoint management that's been around for several years now, where you, for example, you can do either macular or posterior pole, let's call it, laser with endpoint management, or even outside the posterior pole, different patterns. You can have, for example, a square grid, and you have the corners that are visible, so you know where you've been if you want to do a PRP with very, very light laser, or you can have a grid, a circular grid with a safety zone, a fixation light in the center, and a fixation free zone. And you can do a grid, you can do quadrants of the grid. I highly recommend you to have a look at the system to experience that.
And for Professor Midena, how often do you see the patients in the follow-up when you do the MicroPulse laser of the macula?
3 months.
3
not
months.
Earlier.
Not
or longer, because in particular in diabetic macular edema, which is not an acute disease and doesn't change so fastly and doesn't modify visual function, we can only schedule 2 or 3 treatments and look at the patient at the end of this treatment. Nothing happens.
Okay.
Negatively.
I think it's important that we all remember the following. We have to remember that diabetes is a systemic disease. We are treating just the side effect in the eye. But the patient remains diabetic, the diabetes continues no matter what we do, no matter how we treat the patient. So if the diabetes is not well controlled, it doesn't matter what laser we use, it doesn't matter what we inject, the eye will continue to get worse, or the edema or the proliferative disease will recur. So we have to remember to treat the baseline disease as well.
I partially disagree with Paulo, because it's well known now that the complication inside the eye has a different way compared to the situation of diabetes. We know for many years that there are patients with very poor glycemic control and no signs of retinopathy. And the contrary, patients with very strict and good control with tremendous retinopathy. So there are some factors inside the eye, as shown also by the endocrinologists in their basic research, which may modify the approach. So I think that our follow-up of patients with diabetic retinopathy should be strictly motivated by the intraocular situation.
Okay, thank you. I think we can conclude our session. It was really, I think, very interesting, and thank you all for staying with us.